Okay, guys, welcome back. Here's round two. Hopefully, that first part of lesson, unit two, two, that first part one actually sunk in a little bit. You had some time to rest, think about it, even go back if you needed to look at it. So now we're going to get into the part two of lesson two. So this is really just talking about the regions again, some prevention and some procedures. Some of this is a little bit of review, but it is stuff that you absolutely need to know in order to, it's like the bread and butter of the EKG system, okay? All right, so this is just a reminder of what the coronary arteries look like, where they're located, and that they do actually make sure that our heart muscle gets oxygen to it, right? All of these here. This is the LAD, the widowmaker here, the right coronary artery, the circumflex. These are the major arteries around the heart that may have blockages in them. So we're going to look primarily at blockages in those regions. All right, so we have to remember what regions match. Okay, again, I was talking about this in class, how this is critical for the cardiologists and the physicians, the surgeons to know where a blockage might be located. So this EKG is literally going to tell them where they need to go looking. Okay, so it's like a scavenger hunt. They got to go find where this blockage is inside the heart vessel, blood vessel. So the EKG is going to kind of lead them in the right direction, if you will. All right, so let's review all this and put it together. So you're going to fill out your chart here. Whoops, I went too far. So your chart is on this page right here. Yeah, it looks like that. So these are the ones that go together. I color coded them a little bit, and I got to try to get my face out of the way. So, geez, I'm sorry. So if we look at an EKG, you can see this is lead 1, 2, 3, AVR, AVL, and AVF. And then we have V1, 2, 3, 4, 5, and 6. So this is the way, when you look at an EKG, these are the 12 leads that you see in this order, right? AVR is not colored because we don't use this. Anything headed to the right arm, we don't use in our differentiation of regions of the heart, okay? So 1 and AVL, because they both land on the left arm, are lateral. Okay, so that's the lateral region of the heart. So anything across the top of the heart, like that circumflex, okay, is going to be affected in that region. So if I saw changes in lead 1 and AVL, in both of those there, then we have some sort of problem happening in the lateral region of the heart. Same with 2, 3, and AVF. These are all together as well. 2 and 3 and AVF all land at the left foot. So that is inferior. So down below the heart, it's picking up things like in the LAD, way down below. Okay. In that region of the heart, as far as if there's a blockage or whatever, if we have two changes, 2 of the 3 show up with changes in one of these 3 leads here, or 2 of these 3 leads here, then we can say it's diagnostic for an actual change, like ischemia or an infarction, okay? And then when we look at the anterior regions, V1 and 2 are grouped together, 3 and 4 are grouped together, but they are all considered anterior. So I could have a change actually in lead 1 and lead 4, and it would still be diagnostic because they are all anterior. Okay, I'm going to say that again. So I'm looking for any changes in the same region on the EKG. I need to have at least 2 in that region to call it diagnostic. Since we have 4 that are anterior, V1, V2, V3, and V4, all I need is 2 of them to have a change to be diagnostic. And it could be any combination. It could be 1 and 4, 1 and 2, 2 and 3, 2 and 4, 3 and 4. As long as the 2 of them have a change, the same change, then we call that diagnostic. And then with apical, we only have the 2, or they sometimes call it low lateral, V5 and V6. They both have to have a change to be diagnostic in the apical region of the heart. So fill this chart in if you need to pause, if you haven't finished it out on your chart yet. You want to color code it just to make it look pretty. If you want to draw circles around it or highlight it so it looks, you can tell that they all go together. But it's just a visual way to look at it, just to remind us of what the regions are of the heart, okay? If you need to pause it, go ahead and pause it. I'm moving ahead. All right, so if we have an anterior MI, if we have one in the left anterior descending right here at the front of the heart, okay, that means if we have a blockage right here, notice this is a blockage in the blood vessel, so we're not getting blood flow to the area that's kind of browned out here. So I did it again. So if we're having a blockage right here, we're going to see changes in the anterior region on the EKG. That's V1 through 4. So let's take a look on this next page here. So anterior MI involves leads V1 through V4 and occasionally lead 1, but we don't really pay attention to that much. The LAD is affected, so that left anterior descending, that one that comes down the front of the heart, literally right down the front, anterior means front, then you'll see changes in leads V1 and V2. You will see visible ST elevation in leads V1, 2, 3, and or 4. So you can see them down here. This is an anterior MI. We have ST elevation. We learned that elevation means STEMI, right? So in V1, here's our isoelectric line, and this is way above. V2, isoelectric line, J point's up here, way above. Isoelectric line, J point here. Isoelectric line, J point here. Look at this one, way up there. Isoelectric line, J point, ISO, J point, ISO, J point, ISO, J point. So this is what an anterior MI looks like, or anterior STEMI looks like on an EKG. I think we have one more. So on your paper, you see we're on number 19, A, B, and C. So you can see the pictures down there. If you want to circle the same pictures I do, you want to circle the ST elevation and just write down that's a STEMI, just kind of so you have it in the back of your head as you're going through and looking at your notes later. So this is another example of an anterior MI. So remember, anterior region is V1 through V4. So I'm going to go ahead, any EKG I look at, I'm going to look at the different regions. So since we're talking about anterior, I'm going to just jump to anterior. V1, 2, 3, and 4 are all anterior, and I'm looking for at least 2 of them to have changes. Now, here's my isoelectric line. So do you see that ST elevation right there? Notice how it's up much higher than the isoelectric line. That's my J point. Here's a one that looks like the fireman's hat, very tall fireman's hat. There's my J point. Down here as well, very tall and J point. So I have 3 of the 4 leads that have ST elevation. So this is positive for an anterior MI. So now the cardiologist can take a look at this and be like, hey, we have a STEMI in the anterior region. So when he goes in to look for blockages, they know that they're looking in the LAD. They know exactly where to go. There's no like scavenger hunt fishing around needed. Okay, pretty cool actually. It's such a simple thing that you can do. The EKGs, they're very simple to do. It just takes a few minutes to do them, but it just tells so much information to the cardiologist. It's one of the most important pieces of equipment and knowledge and technology that they can use. So it's very, very helpful and important. All right. So a reciprocal change means that if we see ST elevation in one region of the heart, the opposite of it we should see ST depression. That's what that means. So if I have ST elevation in one region, the opposite of it, its reciprocal, would be depression. Okay. So this is kind of a cool example here. So I see ST elevation down here in 2, 3, and AVF. They have it outlined in red. You have this same picture on your paper. So I see elevation. So this is the inferior region, right? 2, 3, and AVF foot. This is inferior. So that's across the bottom of the heart. So the opposite of the bottom is the top. So across the top is considered lateral. So 1 in AVL would be lateral. So if I see elevation in 2, 3, and AVF, I should see depression in 2 in AVL. I see a depression. This is downsloping here and another downsloping. So it's just the opposite. It's the reciprocal change. That just kind of helps us confirm for sure that this is a STEMI because we have the reciprocal change happening. Okay. Again, if you need to pause, go ahead and pause. If you need to review it, rewind it, go ahead and rewind it. We're going to go over all this in class next week. All right, so let's do our reciprocal chart. So when we're looking at our EKGs, right at the front of our heart, V1, V2, 3, and 4, anterior septal around the septum, and the anterior septal is called. We don't have an opposite. The opposite would be the back of our heart, posterior. Okay. So do we put stickers on our back? Not typically, right? So the only way to confirm it would be reciprocal would be if you had stickers on the back, which we're not going to do that. Just in a regular old, if we see ST elevation in V1, 2, 3, or 4, it has to be 2 millimeters or higher. We just know it's a STEMI. There may not be reciprocal changes with those. Now, if we look at the lateral region, 1 in AVL, and even low lateral, V5 and V6, that's opposite is 2, 3 in AVF. And then any of the anterior laterals, so if you find changes in 1 in AVL as well as 3, 4, 5, and 6, you'd see a change in 2, 3 in AVF. Inferior, obviously, if you see a change in the inferior region, the opposite would be the lateral region in 1 in AVL. In the posterior, we can't see changes on a posterior EKG unless we put the stickers on the back. We haven't learned that yet. There is a way to do that, and they do occasionally have me do that just in case if they suspect a posterior MI. So if we had a STEMI in the posterior region of the heart, we would actually see depression in V1, 2, 3, and 4. That's because it's a reciprocal, right? So he has all the signs and symptoms, like major signs and symptoms of a heart attack. And we do the EKG and he has major depression in V1, 2, 3, and 4. We pull a troponin. The troponin says that it's super high. They think there was some sort of injury. They're like, you know what? We think he's having a posterior MI. So they'll actually ask me to put the stickers on his back. And there is a specific way to do it and see if I can get the ST elevation to show up in the posterior EKG. There is a such thing as a posterior EKG. We'll get to that later. I think I do actually have this in the notes, so we'll touch on it today and we'll perfect it later. Touch on it today, perfect it later. So make sure you get that chart all filled in. So the ones that I would highlight are these ones here, the ones that actually have a reciprocal. These do not have reciprocals, but these do. So make sure you know what these reciprocals are. Basically, if it's across the top, it's reciprocals across the bottom and vice versa, right? Okay. And if you need to pause and haven't finished it, pause now. I'm going to move the slide. Okay, so if we have an inferior infarction, so I have a heart attack happening in the inferior region. That's 2, 3 in AVF, right? 2, 3 in AVF. This is 85% of the population that has a heart attack has it in their right coronary artery, that inferior region over here. So it happens down here. Apex's point is that way, and it's happening this way. Okay, so inferior infarction, we see it in 2, 3 in AVF. That's 85% of the population. Okay, so this is where you're going to fill in your notes on 22A, what area is affected or what's affected. So the artery that's affected is the right coronary artery, and it is about 85% of the population that have an MI will have it in the right coronary artery. It's just the most popular place to have it. Yeah. So the inferior region includes leads 2, 3, and AVF, and you'll see changes in at least 2 of the 3 leads. We need 2 to match. If we only have 1, it's considered non-diagnostic. Okay. So an acute MI, meaning we're having it right now, is a STEMI, or STEMI is a type of acute MI, and you'd see ST elevation and or hyperacute peak Ts. Okay. So leads involved for number or letter C, 22C, leads involved are 2, 3 in AVF. And then an acute MI, you will see ST elevation or peak Ts. If it was a recent MI in the inferior region of the heart, we would see inverted Ts in 2, 3 in AVF. And if it was an old MI, like several months ago, several years ago, remember I told you how pathological Q leaves a mark on your heart always, like there's always damage there? You would see a pathological Q in 2, 3 in AVF if it was an old MI that leaves that little marker. Okay, so everything, all the changes will happen in 2, 3 in AVF if we're talking about an inferior infarct, and it just depends on if it's happening now, it happened recently, or it happened a long time ago. And you can tell by what change you see, either ST elevation, peak T's, inverted T's, or pathological Q. So simple. So that picture of an EKG, I think it might be on my next page. So let me flip over. Yeah, so this is the same picture that's on your paper under 22. So let's take a look of an inferior infarct, okay? So inferior, 2, 3 in AVF. We're looking at 2, 3 in AVF. We're looking for, I can see those fireman hats right away. Here's my isoelectric line, and the J point is way above. I see the fireman's hat. So that's elevated here. It's my isoelectric line. Here it is again, J point way up here, elevated. And even over here, isoelectric line, J point is elevated. So all three of them check off. Now let's do a couple things with this EKG. So this definitely is an inferior STEMI happening, right? We can confirm it by looking at its reciprocal, which is its opposite. So that would be up here, 1 in AVL. And if this has depression, which it does, see the depression? Isoelectric line, this is below, isoelectric line below, then we have a definite reciprocal. So this is a yes. This is definitely an inferior infarct. So now the cardiologist knows where to look, right? Into that right coronary artery. That's where the blockage is. They know exactly where to go. No scavenger hunts for them. A pretty cool tool, actually. Okay, so let's talk about lateral infarctions. So lateral MI is going to be somewhere across the top here. Okay, so that's the circumflux right there, a lateral. And lateral involves our 1 in AVL, correct? I'm going to move to the second page here for number 23. So this is number 23, what's affected. There's a picture of one. I think that we'll come back to the picture. So let's go to 23A on the next page. Which artery is it? It is the high lateral circumflex. If it's the low lateral or apical, it's the LAD. So it's one or the other. High lateral, so high lateral would be 1 in AVL. Low lateral apical would be V5 and V6. So if we have changes in 1 in AVL, it's the circumflex. If we have changes in V5 and V6, it's the LAD. The changes that we would see in those EKGs, in high lateral, again, it would be 1 in AVL, and low lateral would be V5 and 6. So again, if it's an acute MI, it's happening now. We will see definite ST elevation or peak T waves in either 1 in AVL or V5 and V6. If it was a recent MI, so it happened a few days ago while the guy was shoveling his driveway, you would see inverted T's in either 1 in AVL or V5 and V6. And if it's an old MI, happened several months ago or several years ago, we'll see that pathological Q. And again, that pathological Q is not obvious, it's subtle. And I'm going to show them to you in class next week. Old MI shows a pathological Q in either 1 in AVL or V5 and V6, depending on if it's low lateral or high lateral. Are you getting the idea now? It's repetitive, right? All right, I think we're gonna go back and take a look at that EKG that was on number 23. I think that's what's next. Pause it if you need to. Yeah, so here's your EKG that was on 22. So this is supposed to be a lateral infarct. So any EKG, I just go ahead and start looking at the regions. So I start with 1 in AVL first because it's up top. It's at the beginning. And I see that ST elevation because here's my isoelectric line and here's my J point way above. It looks kind of like the fireman's hat, right? ST elevation in 1, let's confirm that AVL also has that isoelectric line, J point way above. 1 in AVL, we definitely have a lateral, this is high lateral infarct happening, STEMI. So it's reciprocal, opposite is the 2, 3 in AVF. So let's go see if there is ST depression in 2, 3 in AVF. 2 actually looks kind of normal. But when I go to 3, there's some downsloping. AVF, it's depressed, it's horizontal, but it's definitely below the isoelectric line. So I have 2 that match. So ding, 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 we have a match. This is lateral STEMI with reciprocal changes in the inferior region of the heart. That confirms it. Okay. Hopefully you got that. Just rocking and rolling right along here. So let's talk about that posterior MI. Oops. I knew I went too far. Okay, so posterior MI, you're going to see some ST depression in V1, V2, maybe V3 and V4. But because it's the reciprocal, it's the opposite of the back, it's the front, we're not going to see ST elevation, we're going to see depression. Because technically, if we'd put the stickers on the back, we'd see the elevation because it's happening in the back. So it's picking up, it needs to be in front of it to notice it. Okay, so keep in mind that the posterior region of the heart is seen as a mirror image on the EKG. So that's important to know. Because of this, the MI that you see in V1 and V2 is going to have ST depression instead of elevation because it's the mirror image. So this is actually a really good example of a mirror image. So this looks like a STEMI, right? We see the elevation, but what we're going to see is its mirror image. We're going to see it kind of upside down. So this is ST depression, but if I flipped it over, it looks like elevation. Yeah. So that coronary artery that's affected is the RCA. As it wraps around the back of the heart. Okay, so this RCA in the back. You'll see leads with EKG changes in V1 and V2, and you will see an ST depression usually with a very tall R wave. So big QRS. It's rarely an infarct by itself. It says usually it's in a combo with something else. If we were to take a posterior EKG on this patient, then leads V7 through V9 would have ST elevation. And you're like, wait a second, we only have to V6. What's the 7 through 9 thing? So when you place a posterior EKG, you're going to remove V4, 5, and 6 from the front of the body, and you're going to place it on the back, right under the scapula on the left-hand side. And it becomes V7, 8, 9. Okay, so you're taking 4, 5, and 6 off, putting it on the back where 7, 8, and calling it 7, 8, 9. In that order. 4, 5, 6 becomes 7, 8, 9. So when you take that posterior EKG, and I do get doctors ask me to take them because they suspect a posterior MI, the only way to confirm it is to do a posterior EKG. And you take it and it has that ST elevation, we know for sure that we have a posterior MI. Okay. So here's some pictures. This is kind of what a posterior MI looks like so this is a anterior. It's a posterior MI, but this is a regular EKG that we did on the front. And you can see in V1, 2, and 3, we have this ST depression. Okay, and 4 actually, ST depression. They have all the signs and symptoms. So they're like, you know what? Let's just double check and make sure that it's not a posterior MI. So I'm going to take my 4, 5, and 6, remove them, and put them on the back right here, 7, 8, 9. So this is our BOP, blue, orange, purple. These are not the right colors. Instead of 4, 5, and 6, they become 7, 8, 9. When you print the EKG, you write across the top, posterior EKG, and you cross out V4, V5, V6, and you write V7, V8, V9 on the EKG itself. So once we did that, we turned it around and we did an EKG, repeated the EKG as a posterior. Then look what we have in V7, 8, 9. We have the elevation. So this gets flipped over, basically. Flipped over the other way, it's reciprocal, upside down. And that's how we confirm a posterior MI. Yeah, it's a real thing. Kind of cool. Not cool, but kind of cool that you can figure that out, right? Yeah. All right, I like charts. So I just had this chart filled out. And you can see, I have to move my face around a little bit. So I have it set up for region of heart, all the regions, the leads that are involved, the blood vessel supply, so which blood vessel or artery does that include, what happens when there's an acute MI, so it's a heart attack happening now, and what happens when it's an old MI, okay? So it's nothing we haven't talked about before. It's just putting it all into a chart where it makes sense. So I like to have this all in a chart. So I have one place, like one-stop shopping, if you will, and put my face over here. All right, so lateral is 1 in AVL. This is your left circumflex. And then the ST elevation would be 1 millimeter or a peak T, and an old MI would be a pathological Q. Inferior 2-3 in AVF, that's a RCA. Again, this is 85%, right? You would see ST elevation up to 1 millimeter or peak T, and an old MI would be a pathological Q. So anterior right and anterior left septal, these kind of get all grouped together. V1 and V2 are on the right of the septum, V3 and V4 on the left of the septum. But these are supplied by the LAD. This is your widowmaker. So ST elevation at 2 millimeters. So it's going to be a little bit higher than it would be over here, a peak T. Now an old MI will show a poor R wave, or the R wave is gone. Okay, I'm going to show you some examples in class. And then this is the same thing, exact same thing. Apical and low lateral, a 5 and 6, LAD might be the RCA. You're going to see that 2 millimeter ST elevation, a peak T, or a pathological Q. And then our posterior EKG, V1 and 2, and or V7 through 9, it does supply the RCA. You're going to see that ST elevation again at 2 millimeters in V7 through V9 or large R waves, and then a pathological Q would be there, possibly in the 2-3 and AVF region, just depends. We don't always do a posterior EKG on somebody, so you may not see the changes every single time because it's not a posterior EKG. The damage is in the posterior region of the heart, so you may not see that, might not see the pathological Q on there. I'm not sitting here for very long, so if you haven't finished filling in the chart, just pause and press play when you're done. Moving on. All right, so let's talk about an NSTEMI a little bit. Okay, so an NSTEMI is a non-ST elevation myocardial infarction. So it's still a heart attack. It's still happening right now. Okay. It's also considered what's called a subendocardial infarction. So an infarction in the subendocardial level, myocardial necrosis without ST elevation. So we don't see the changes on the EKG. So how the heck do we know that to have an MI? Number one, they're going to have a ton of symptoms, right? They came in because they don't feel good. They have chest pressure, they're diaphoretic, they're gray, they're dizzy, they're having jaw pain, all the signs and symptoms that go with a heart attack. I hook them up to the EKG, and the EKG actually looks normal. We're like, I think this is probably NSTEMI. I meant to tell you this in class too. I did have an NSTEMI over the weekend at the hospital. Perfectly healthy dude, didn't look right. EKG was okay. Little changes here and there, nothing major, nothing to call a STEMI at this point, but I just knew he wasn't right. We ran his troponins and they were through the roof, so he was having an NSTEMI. Yeah. So troponin levels do increase within 48 hours after you've had the MI. So it's important to repeat those troponins every 3 to 4 hours and just to see how they're trending. We want them to trend down. If they trend up, it's getting worse. They may be elevated for even up to a week after you've had an MI, and then they typically tend to trend downward. So the creatinine also will be elevated for 3 to 8 hours, but you'll see ST depression and or T-wave inversion occasionally on an NSTEMI. Sometimes literally the EKG looks absolutely normal. You're like, how is this an NSTEMI? Or you'll see a little ST depression and or T-wave inversion, just to kind of like throw you off the trail, I guess, because those mean ischemia. So you might see a little bit of ischemia coming through, but you don't know it's a full-on STEMI until, or that it's full-on heart attack until you get in there and look around. Okay. All right, so what does a STEMI mimic? So our regular EKG looks like this, right? Our ST segment is right on the baseline. And STEMI, we sometimes see some depression. A regular STEMI, it's up high. And STEMI, you might see a T-wave inversion. These both lead us to believe that there's some sort of ischemia, like I said. But just because it's ischemic doesn't mean they're having a heart attack. So it's kind of misleading. So what does the STEMI mimic? I would say depression or T-wave inversion, which equals ischemia. So it does look like ischemia or can look like ischemia on the EKG when it's really a full-blown heart attack. We just can't see the change. Now I have to tell you that most of them do not end up being end STEMIs, okay? I have much less end STEMIs than I do STEMIs, for the record. All right, so after we've had a heart attack, we end up with something, this next one here, the pathological cue, okay? So when and how does this develop? Keep moving my face. So it happens right here. And again, I explained this to you the last lesson, was the pathological cue is normally very, very skinny and not very deep. Okay, so it's shallow and skinny. When a pathological cue happens, we have that damage to the heart. It starts to form at the STEMI spot. And then as you come out of the heart attack or out of the STEMI, it stays there permanently for the rest of your life. It's a damage to your heart. So that Q wave will be deeper and wider than it was before. Okay. So it's really easy when you have a before EKG and after EKG to point it out. But if you've never seen the before EKG and you're just looking at the pathological cue for the first time, it may not look like anything. You have to really kind of look at it and judge it in the way the size and shape is. And it's subtle. Once again, subtle. Don't look for it to jump out at you. It is subtle. I don't hang myself up on this for very, very often. This is not something you have to drive into you and you have to know every single time. You just have to know what a pathological cue is. Okay. Yeah. Here's some normal examples of it. We see the Q wave up here. It's short and it's narrow, and it changed down here. See how it's much wider and deeper. So this Q wave compared to that Q wave, very different. This Q wave compared to that Q wave, different, wider and deeper. Same over here. Narrow and not so deep, wider and deeper. That's our pathological cue. See how subtle it is? It's not very, it doesn't jump out at you. You have these same pictures on your note sheet if you want to circle the pathological cue and put a note that it's deeper and wider. That might help you a little bit. All right, so ST changes chart. So this lets us know basically what you're seeing on the EKG means yes, it's definitely that. No, it's definitely not that. Or it may or may not be that. You don't know. We have to do more tests to figure it out. So when you see ST elevation on an EKG and you have two of those leads in that region match, it is an acute MI. It, yes, definitely is an acute MI. It's happening now. ST elevation does not mean you had a recent one. It does not mean an old one. It only means acute. It's happening now. So peak T waves sometimes mean you're having an acute MI. They don't always mean that, but they can. Okay, so it's a may or may not. Peak T waves do not tell you it was recent. It wasn't a few days ago. It's not telling you it was old either. Okay, so peak T waves may be there for acute. Peak T waves mean other things too. So our next lesson is called Understanding T waves. I'll explain that more in our next lesson. Inverted T waves may or may not be present in acute MI also. Remember when in our phases of a heart attack, we had peak T's, STEMI, and then as it started coming back down from the STEMI, the T wave turns over. So you may have an inverted T wave at the end of that acute MI. You will always have inverted T waves in a recent MI. So recent means just a few hours ago, a few days ago, even up to a week or so, 2 weeks ago, you'll see inverted T waves. The more deeply inverted they are, the more recent it is and or more severe. Pathological cue may or may not be there during the acute MI, may or may not be there during the recent, but will always be there in an old MI. Okay, so it may or may not be there. If this is the first heart attack they've ever had, it may or may not be there. It will definitely be there in the old MI. Another great chart to keep handy. Definitely have this handy for your test, okay? All right, we're almost done here. We're just gonna wrap up some testing that we do and have some practice EKGs at the end. All right, so we know all about treadmill stress testing. You can take the notes that you want to on this. We've taken lots of notes on stress tests. You don't have to write anything if you don't want to. But basically, a treadmill stress test is when a patient walks on a treadmill at a preset pace and slope while the doctor monitors their EKG, changes blood pressures and symptoms. Okay, so we're testing for ischemia on the treadmill. We're testing to see if any EKG changes led us to believe that they had an ischemic response. We don't do treadmill stress tests on people that have had high troponin levels. That means they already had damage to their heart. We don't want to put it under more damage or more stress. The pharmacological stress test is that test for those people that can't walk. They just physically can't walk. Maybe they don't have two legs. Knee replacement, hip replacement. They're just getting old. They walk with a walker or a cane. It's unsafe for them to be on a treadmill. So we're going to give them the liquid treadmill, basically, the pharmacological one. So medication is injected in there that kind of simulates what happens when you exercise. We've talked about that too. Again, we will not do any type of stress test if their troponin levels are high. So we always check at least 2 troponin levels and make sure that they are normal before we do a stress test, no matter what type of stress test it is. An echocardiogram is basically just an ultrasound of your heart muscle. It's a different way to look at the heart because you can look at it actually squeeze. You can watch the cardiac output, the ejection fracture. It's called the EF. And you can in real time, watch the ventricle squeeze, the valves open and close. It's actually really cool to see if you ever get to watch one. So it's a way to check to see if the function of the heart is still working. Again, write what's relevant for you. This is your notes. So write down what you feel is important for you to know. And if you're not quite done, just pause. All right, so how do we prevent this from happening? I don't want blockages. I don't want to have an MI. How do I prevent myself from this happening? So there are medications that you can take if you have a known history of it or there's a strong family history. Obviously, see your doctor regularly and make sure that you're doing your checkups. You check your blood pressure regularly, have a stress test when you turn a certain age, all that stuff. So you may take medications like blood thinners, beta blockers, vasodilators, diuretics, and statins. Those are people that are known to have a heart condition, have had prior surgery already, or have a very strong family history, and they're just doing it as a preventative. Okay, so these are preventative medications once we found out that something might be brewing in there. Obviously, exercise. All of you are in the right field if you want to help people that have heart blockages. Exercise is the number one. Healthy diet, low fat and salt, rest and minimal stress. This is my lifestyle right here. I exercise. It's not. I'm kidding. I try really hard. I strive so hard for the rest and minimal stress. We all do, but going to school in itself can not leave you much rest and lots of stress. So hopefully you're doing the other things. You are exercising and eating a healthy diet at least. The rest and minimal stress will come later, right? Yeah. So this is literally exercise and diet is the cure-all for everything, for most things. So here are some procedures that we have to do just in case there is a blockage or we suspect a blockage. Okay, so we suspect a blockage. We saw some ST elevation and we found out it was in the inferior region of the heart. So this doctor is going to now take a catheter. So a catheter, everyone thinks of a catheter in your urethra. A catheter is just a name for a tube. Okay, so a special type of catheter is inserted in a vein near the groin area. Sometimes they use the wrist. And then it travels up to the heart where the doctor will inject some dye into those arteries that surround the heart and they'll watch it at real time under x-ray. Okay, so this is the cardiac catheterization. So they're putting that dye through the blood vessels and watching it in real time in X-ray, and they can see if it didn't get to that region of the heart, there's a blockage there. 9 times out of 10, they can stent it. Okay, so if that blockage is more than 70% blocked, but not up to like 99% blocked, if there's a little bit of opening in there, they can place a stent. And that is the least invasive way to take care of blockages in your heart arteries. Okay. Um, so what are stents? They're little mesh things. There's a picture of them down here, actually. They remind me of those. We used to call them Chinese handcuffs, and I know that's not the right terminology anymore. But they were the things you can stick your fingers in, and you couldn't pull them back out again. They look like that. Okay, so they get inserted into the blood vessel, very very small and teeny tiny, and once they get into the blockage, they get it through that tiny hole of the blockage. Then they use angioplasty, so they use a balloon that they insert and blow it up, and it opens up that blood vessel, so it opens up our pipe again, and that stent stays there for the rest of your life. Okay, so this is kind of what it looks like before, and then they place the stent in. You can see it sliding in, and then they blow it up, and now we have perfect blood flow. Now, if it's too blocked, it's too gone, it's 99% blocked, 100% blocked, we can't get a stent in. Okay, they're going to have to do what's called bypass surgery or CABG. Yes, CABG stands for coronary artery bypass graft. Coronary artery bypass graft. Okay, so this is a bypass. So what happens, this is kind of a cool picture of one down here. So what happens is we have a complete blockage, like say the road is blocked, right? Something fell on the road. We can't get around it. There's trees and branches in the road. We can't get around it. We need to create a bypass, a roadway around it. So that's what they do inside with your blood vessels. They'll take a vein from your leg and they'll attach it. My blockage is here. They'll attach it above the blockage and then again below the blockage, and it creates a bypass highway around that blockage so that that lower part of the heart still gets oxygen. So if someone has a quadruple bypass, that's 4. Quad is 4. That means they had 4 blockages and they put 4 new pathways around those blockages. I had a friend that had 5 bypasses done in one procedure, and he was only 48 years old. Crazy situation. I was right there front and center for everything too. I was like, I want to see all this. Yeah, I'll tell you about that story another time. So bypass surgery is the last resort. And that is basically called open heart surgery, where they have to open you up and actually go in and manipulate the anatomy inside your heart. All right, hopefully you got all that. We can talk about more in class. So I did want to go run through some interpretation. You do not have these in your packet. I am going to go over them in class as well. So we'll just take a quick look at them and then we'll go over them in class. Okay. So this is EKG number 1. And I always group them together. 1 in AVL, 2, 3 in AVF, V1 through 4, and 5 and 6. Okay. I'm not going to give you any answers today. Just take a look at it. If you want to take a picture of it and look at it later, you can. I think I have 4 or 5 of these, but I think that I am going to just save these for class. Yeah, I'm going to save them for class so that we can spend some time looking at them together, and I'll have a few more in addition to this. All right, hopefully you understood everything. You obviously can go back and rewatch it anytime you want to. This is all you had for your assignments this week, was to watch the 2 videos and take the notes. We will review all this on Monday before we head back to the lab. If you have any questions, please let me know. Have a great week.